Hey everyone, this is Jose, and today I will be discussing about myocardial infarction. Myocardial infarction, so this is when the coronary blood flow is interrupted for an extended period of time and a myocyte necrosis occurs. And this also results when there's a prolonged ischemia that causes irreversible damage to the heart muscles. There are two types of myocardial infarction. The first one is the subendocardial infarction, and this is when the thrombus breaks up before the complete distal tissue necrosis has occurred. The infarction will only involve the myocardium directly beneath the endocardium. The second type is the transmural infarction. This is when the thrombus lodges permanently in the vessels. The infarction will extend through the myocardium all the way from the endocardium to the epicardium, resulting in severe cardiac dysfunction. Risk factors for MI are smoking, diabetes, dyslipidemia, hypertension, and family history of heart disease. The pathophysiology of myocardial infarction starts when the atherosclerotic plaque partially obstruct the coronary blood flow. Then there will be rupture and thrombosis of unstable plaques. There will be acute coronary syndrome that will lead to ischemia that results in myocardial infarction, and there will be inflammation and necrosis of the myocardium. Clinical manifestations of myocardial infarction are there's a sudden severe chest pain that can be described as heavy or crushing. There's going to be dyspnea, diaphoresis, feelings of anxiety, tachycardia, and pulmonary congestion. Diagnostic tests, we can do a 12-lead ECGs. This can identify the location of the affected area through changes in the ST segments and the T waves. We can also check the cardiac troponin I. This must be tested as soon as possible, and this is the most specific indicator of MI. And we can check the CPK-MB. This test can also identify MI, because this is one of the biomarkers released by the myocardial cells. We can do an echocardiography. This can help assess the function of the right ventricular MI, cardiac wall abnormalities, and the valve lesions and functions. CT scan, this imaging can be done to check ventricular function in the pulmonary embolism. And this also has a better sensitivity than the echocardiogram. For plan and treatment, definitely hospital admission is needed for myocardial infarction. Then we need to provide supplemental oxygen for hypoxia. So this is to ensure that oxygen saturation within the blood is optimized for delivery to the myocardium. We also need to assess for patients' glucose. Hyperglycemia is noted approximately 72 hours after an acute MI, and this is also associated with an increased risk of death. Administration of aspirin is the mainstay treatment for patients undergoing pharmacological or catheter-based reperfusion. And for the pain, for the chest pain, we can treat that with sublingual nitroglycerin. Nitrates improve coronary blood flow through vasodilation and decreases vasospasms that help reduce oxygen demand. Morphine sulfate to treat chest pain. Based on my literature review, some studies suggest the use of morphine to lessen chest pain or discomfort because it also decreases oxygen demand. But other literature that I have read does not recommend the use of this medication because it delays the action of the antiplatelet medication. And percutaneous coronary intervention, such as angioplasty, study shows that this procedure helps lower death, heart failure, and reinfarction within 6 months. And these are the references that I used for my presentation. And if you have any questions, clarification, or anything you guys want to add, feel free to shoot me a message. All right, thank you.